So welcome. It is May 2020 and we are in the midst of the COVID-19 pandemic. My name is Kath Murray and with me is my dear and esteemed colleague and associate Anne-Marie Gilbert.
Hello.
In a minute we'll have a nice PowerPoint slide up and it will have Anne-Marie listed as the scientist and superstar. Maybe you would like to give your credentials a little bit more succinctly than that, Anne-Marie.
I am a researcher at heart, have always been. I have formal training at a master's level in biochemistry of nutrition, and I've been doing research in life and professionally for over 30 years, but mostly I love writing.
And Anne-Marie has become a palliative care expert as she's worked over the last decade with Life and Death Matters and as a family caregiver. So I often say she's my right-hand person, but I guess she always reminds me she's left-handed, right-hand. Anyhow, so, and my name is Kath Murray. I'm a hospice palliative care nurse, educator, and author with the Life and Death Matters team. Our goal is to improve hospice palliative end-of-life care through delicious and digestible resources. And today is one effort to try to help people access the resources that are available in regards to COVID-19 and difficulty breathing. So we're just going to do a quick overview of a couple points, a couple resources. We also would like to welcome the Facebook group. In particular, we're going to post this specifically for the Facebook group, so you get first dibs at it. And what a treat it is and what an honor. I know many of the people on this group, but many I don't know, and so look forward to meeting you. Our hope with the Facebook group is that it's an opportunity for people who are also committed to hospice palliative end-of-life care and to people who are committed to hospice palliative end-of-life care and who want to explore together and share experiences, wrestle with questions and concerns, create new friendships, and network together. So right now, I'm going to share my screen. And as we're all working from home right now, we're dealing with people coming and going in our home offices. So welcome. And Anne-Marie has just come back from walking the dog at the beach, so she's cold, even though it's nice and warm out. We are recording this session for the purpose of sharing with the Facebook group and invite ideas and comments and questions. The resources, the backdrop to this presentation, to just give me an outline to work with, is the PowerPoint presentation that has been developed for Essentials in Hospice and Palliative Care, a practical resource for every nurse. And we also recommend, I highly recommend, the Pallium Canada webinar series related to COVID-19, in particular for managing dyspnea in patients with COVID. I recommend the presentation on April 14th, 2020 by Doris Barwick and Dr. Shalini Naniar. Excellent piece, and I will come back to this a couple times. They mention in there the UBC Division of Palliative Care materials that Dr. Pippa Hawley coordinates. Pippa is incredible and provides does such good work on putting together resources and making them available to people. The BC Centre for Palliative Care also has some excellent resources, both for healthcare professionals and other caregivers and family members. We are delighted in the time of COVID-19 to make available to you excerpts from the nursing text, Essentials in Hospice and Palliative Care, a practical resource for every nurse, and excerpt from the Integrating a Palliative Approach, Essentials for Personal Support Worker text that we've written that have to do specifically with increasing comfort for people with difficulty breathing. You can access those free of charge at this time, as well as you can watch the video series specifically on dyspnea by going to the lifeanddeathmatters.ca site and looking at for the COVID resources. So to look, I just want to add a couple pieces to our discussion about dyspnea. In the videos that have already been done, you'll find some really good overview and a nice, easy presentation style about difficulty breathing, about dyspnea. In the text, you will find a much more thorough piece of what I'm touching on today. So that is where you can get your teaching materials. That is where you can, and the videos I mentioned with Palliative, I think are your best resources for going in depth now. When teaching about dyspnea, for some people that's a new word, but the important thing about it is that it's a sensation of difficulty, of struggling to breathe, and it is what the person says it is. It cannot always be measured by objective means. And this is really an important piece for family to understand, because sometimes family just think, oh, they need oxygen, or they can't breathe, or they don't look like they're short of breath, but the person's saying they are. So important for family members and all of our healthcare team to understand just what a personal experience this is. It's one of the most feared symptoms among people with respiratory illness, and I think at this point we can pretty safely say that anyone who knows about COVID-19 knows about the need for ventilators, and why do you need a ventilator? Because you're having difficulty breathing. And so the whole level of severity between having a cough and a bit of shortness of breath this is something that's probably feared by many people at this time. In COVID-19 suggestion with Pallium's, their quote was just under 68% of people will experience a dry cough. That might be mild, that might be quite severe, and shortness of breath just under 19%. And again, might be mild shortness of breath, but can escalate quite quickly and become severe. In the research that Anne-Marie had done, suggesting that people with COVID-19 will usually begin experiencing breathlessness approximately 5 to 8 days after the onset of symptoms, and that a person who experiences dyspnea with their infection may have a more severe illness than someone who does not experience dyspnea. So Anne-Marie, do you want to say, is there anything else you want to say about that at this point?
Not right now, no. I think you should keep going.
Okay, and I think one of the fears with the onset and is the rapid increase, the rapid escalation of difficulty breathing, which must be an incredibly frightening experience for the person experiencing it, but I think equally frightening for those who are caregivers. Mm-hmm. We think about the things that cause difficulty breathing. The anxiety alone can contribute to it. Cardiovascular issues can affect, neuromuscular, pulmonary causes. But with COVID-19, Dr. Nair in the Palliative video, right at about 8 minutes and 20 seconds, does a fantastic couple illustrations and explanations of the different things that cause lung injury. And I like that word, lung injury. I don't like the word, maybe that's not, I think it's a nice term for addressing the fact that our lungs are being hurt by this disease. And I think that going to the Palliative website, looking at the Palliative COVID resources, and going to that webinar is well worth it. And in there's the point that if someone does have underlying disease, i.e. COPD or asthma, then to continue to treat those illnesses is so important. Mm-hmm. And again, here's the reference here, and you have that. So I'll just leave that up for a minute. So you can see that.
Mhm.
An excellent resource. I have such esteem also for Dr. Doris Barwick, who's just done incredible work. And they also in that mention a couple other articles. So further study, an additional study and resource would include the BC Centre for Palliative Care and the BC Division. So those are a couple resources I'm especially familiar with right now. I know McMaster has also done materials, and I know that across North America we see a number of things popping up and available. So the experience of dyspnea, the body communicates and understands this through mechanoreceptors as well as chemoreceptors that are reflecting. And so in the midst of this, you've got this whole system that's working. And I remember Della Roberts years ago saying, you know, there's however many difficult things that can go wrong. Shortness of oxygen or lack of oxygen or decreased oxygen is just one of them. And how complex this system is. Wonderful example here of mechanoreceptors located throughout the airways, the chest walls, and the lungs that detect if there's a problem. So how do we assess it? And the only reliable measure is the person's self-reporting. So the Edmonton Symptom Assessment System is excellent in terms of just doing an initial screening. So do you have any shortness of breath? Can you rate it on a scale of 0 to 10? 0 being no shortness of breath, 10 the worst possible, worst you can imagine, and having somebody identify it. If somebody's short of breath, then going on and using the symptom assessment tool. And I think of that as being the OPQR-STUV. So asking O for onset, when did it start? P for palliate or provoke, what makes it better, what makes it worse? Q for an OPQ, quality, can you describe it? How does it feel? Where do you feel the stress? R, region and radiate, where do you feel it? S, severity, can you rate it on a scale of 0 to 10? T, treatment, what have you tried? U, what is your understanding? V, what is your value? What are you hoping? And W, is there anything else? So just being able to use that framework to help you collect the information so that when you go to report it, you're more likely to be heard. And similarly, that is something that a family member can learn and can do so that the family member can better report it. I think one of the most frustrating things and scary things is being a family member or a caregiver and not knowing what to do and what's helpful. Mm. So the non-pharmacological measures, of course, responding immediately at the first signs of dyspnea, and in particular with COVID-19. I think this is especially important. All of the things that you would do for somebody with non-COVID-19 dyspnea, you would continue to look at and do. So here's some examples. They're in the text. They're in the text. They're in the videos. Mm-hmm. The one thing though that's different is the airflow. We typically talk about the benefit of opening the window or putting on a fan and getting the air moving. The concern about this is the spread of the droplets. So generally speaking, if the idea is not to encourage the airflow, if BiPAP or CPAP machines are used, or if a fan is being used, then this would be a time when everybody else should be wearing their PPE. I would think that living where I live, out in the middle of farmland, that in my case, I would open the window and that would be okay. I would think if I was living in congestive housing and dense population, that might not be appreciated. So again, to just think about airflow and safety. And how important for us to be able to teach caregivers the importance of being calm. The idea that calmness can be contagious. The idea that by being a calm presence, by coaching somebody in their breathing, that we can be helpful is, I think it's a positive and helpful thought, and it's something we can implement and something that family members can do. So again, similar strategies for working with anyone. If we can get that dyspnea settled, then that might be the time to do the assessment. When somebody is struggling for breath, probably isn't the time to ask the questions. But then once we've got them settled, once we've got them breathing more comfortably, consulting with the team and deciding a plan for symptom management, educating family about preventing and responding to dyspnea, and consulting with the person who they want us to connect with. If somebody's condition is changing quickly, I usually say never waste a good crisis, but right now you're in the middle of a crisis, and whether this person's going to get better or not is you may be in a situation where it's really not clear. Hopefully before this you've had opportunities to talk and have serious illness conversations and talk about goals of care and talk with family, etc. But if not, this is when the person's a bit more settled, essential conversations to have.
Can I just interject
Please.
for a second?
Right.
Can you go back one slide?
Yeah.
And where we see consult the healthcare team for symptom management, one of the recommendations from the Government of Canada in terms of managing people with moderate or severe COVID-19 infections is to consult with your healthcare person, whether it be telehealth or, depending on your location, consult with them as soon as you notice that the person is starting to have any sign of difficulty with breathing. And if you're a nurse, you would start tracking that using the ESAS, checking in with them, because this isn't something you're expecting to settle. You have to go forward with the expectation that it is going to become more severe. That seems to be the way the infection goes. You need to check in with the person hourly to make sure, or even every half hour, and you have to be in contact with the resources that you may have to access should this person need to be moved somewhere else. So that's the big game changer for this. Once a person has some shortness of breath, they are on a separate track for treatment.
Thank you, Anne-Marie.
Okay. Welcome. Okay.
So mild to moderate dyspnea, continue to treat as one would with any difficulty breathing. There is, whether it's an upper airway infection or symptom, or lower airway effect too, and what can be used. So if somebody's got lots of secretions in upper air, Palliative Canada highlights the different protocols that do suggest the use of glycopyrrolate, scopolamine, or atropine, depending on what your health authority is using. If it's a lower airway infection, diuretics might be helpful, steroids might be helpful, and I think I'm going to leave that to that Palliative group to comment on further. Oxygen, yes, and again, Dr. Barwick and Dr. Nair talk well about oxygen and how that's applied. Just want to comment though, the big deal is over the last few years, our whole push with palliative care has been to integrate a palliative approach. However, and by that meaning integrating principles and practices of palliative care for people early in the disease process, living with any serious life-limiting illness, and across all care settings. This is a really good example of a disease where using the opioids early in illness may be very helpful and provide good comfort measures. So with this might not be an area that the team that you're working with is familiar with the use of opioids. totally appropriate to contact the palliative care teams, the specialists in your area, to discuss the use of opioids for dyspnea. Anne-Marie, did you want to comment?
No, go ahead. I agree. Okay. I agree.
Reducing opioids reduce the sensation of dyspnea and may in fact increase survival by decreasing distress and exhaustion, though I don't know that we've got the stats in on that. And the importance of titrating to optimal dose and comfort. Mm-hmm. Now, when somebody is in last days and hours and they are dying and they are dyspneic, then palliative sedation would be another tool to consider. And the health authorities generally have their policies on that, and totally appropriate, again, in this illness to look at that. Now, I think that there were a couple other comments that I wanted to make, but, and I've gone blank, so isn't that a lovely thing to do in the middle of a webinar? But I think the important things, for me, the most important resources for you are the handouts that we have that are available for download, the excerpts from these 2 textbooks, the video series, excuse me, on dyspnea, and that can be accessed here, and the Palliative video with Dr. Pippa, with Dr. Doris Barwick and Dr. Nair. Okay. So, and
I'm just going to, when we post this to the Facebook group, there'll be a link in there for you to gain access to the video series and the downloads. Great. So that link will be in the Facebook group when we post this.
Great. And look forward to hearing contents and comments from all of you as we go. So thank you. And thank you, Anne-Marie.
Thank you.
There we are. Our contact information, and Anne-Marie's is Anne-Marie at Life and Death Matters.
All right.